Hello, and welcome back to another episode of the 2020 podcast, Canada's #1 optometry podcast. I am your host, Harbir Sayan. Thank you so much for taking the time to join me here, guys. I always appreciate all the support, the fact that you take time out of your busy schedule to join me here. I'm very excited. We are at the Thea Pharma Canada offices here in Toronto. I want to say a special thank you to Thea Pharma Canada for sponsoring this episode. This episode is part 3 of a 3-part discussion that I'm having, 3-part series of discussions that I'm having with this wonderful, wonderful person here, as who you all know is Dr. Claudine Courey. And the last couple episodes we did, they're all on different topics. So the first episode we recorded was more about entrepreneurship and Claudine's journey through optometry and all of that, and sharing her story. The second one was about clean beauty, understanding what's in beauty products, what's good for our skin, what's good for our eyes. And today we are going to do a deep dive into dry eye. I know we've talked a lot about dry eye over the years, but we are sitting here with an expert, someone who literally does this every day, is going to tell us how to get started if we're in the beginner stage, how to elevate if we're in the middle, and give us some more pearls. Even if you're an expert and you're doing a really great job, I know there's going to be some more pearls that Claudine can share with us. So thank you, Claudine, after that very long intro. Thank you so much for joining me in this part 3, the third and final episode. Yeah. Thanks for being here.
Thank you so much for having me. These have been so much fun, and I can't wait to talk about this one because it's my absolute favorite topic.
Yeah. This is what you do.
This is what I do.
You live and breathe this every day. So thank you. So quick intro. I'm going to ask you to do a little bit more of an intro for yourself in a second. But Claudine is, of course, an optometrist practicing in Montreal. She runs 3 dry eye practices, also works in a primary care practice. She is an entrepreneur as well. She has started the Eye Drop Shop, which is an online store for eye care products. But Claudine, tell us a little bit more. What else do we need to know? What qualifies you right now to be sitting in the hot seat?
So it's been about 5 years that I really dove in headfirst to dry eye. And I work in an OD/MD practice, and it kind of came about because I really love doing sclerals. That's what I did my residency in, and my friend had called me and she said, will you come sort of do sclerals for dry eye? And that was my path into this whole field. And then after spending the first couple of days fitting sclerals, it kind of naturally evolved into me seeing patients and doing workups, and I absolutely love it. I think it's such a great way of helping patients' quality of life, and we have so many great opportunities and so many great things to propose now these days that it makes it even that much more fun.
Yeah. That's interesting that sclerals was like your way into it.
Yeah.
Like that's sclerals for, I think, anybody who is in dry eye feels like a very advanced stage to come into dry eye. So that's interesting. That was your point of entry. So we'll talk a bit about scleral lenses for sure, because I think that's something that many of our colleagues have thought about, talked about, as how to potentially implement that into a dry eye strategy. But we want to start kind of in the early stage of a journey. So for me, I'll rewind the clock like 5 years. Okay, I did not. So here's what I was doing in my practice 5 years ago. Okay, confession.
Let's hear it.
All right. So I was not retailing any products.
Okay.
I was handing out samples of eye drops that patients would then go buy over the counter. Okay. And I wasn't recommending any dry eye treatments. I may have been suggesting maybe that patients go home and put a warm cloth on their eyes for a few minutes, but that was pretty much the extent of it. So let's go talk to Harbir at that stage, and what do we need to say to him to, give him the information he needs to get started. I wanted to do dry eye, I just didn't want to invest in all the tools and all the technology and all that stuff at the time.
I understand. First of all, I would tell Harbir it's okay. We all started there. You know, we got to be honest with ourselves.
I'm glad I got that off my chest. Thank you.
You're fine. You're going to be okay. No, but we all started there. We were all doing that. At the end of my optometry school was when it was getting really popular to no longer sample, right? So my residency director and everything, like that's when it was kind of getting into, okay, we don't want to sample anymore, we want to prescribe, that's going to make people more compliant. So there's all that kind of stuff. But truly everybody starts that way and it's fine. I think the truth is that these patients are already in our chairs. So first steps first is to open up the conversation and to do things that we already have, right? To start doing a questionnaire while your patient's already waiting for you to see you is such an easy thing, right? To stain with fluorescein, we do it anyways, just to look at different things. To express meibomian glands, to use a pen light to kind of avert the lid a bit and try and see the morphology. There's things that we have in our clinic that we can do right away and that'll help us with diagnosis, and then there's a slew of treatments that are great to kind of already embark off the bat.
Right. So we'll get into the treatments in a second. But as far as from a diagnostic perspective, right, so I was thinking I got to go buy a mybographer right away or some other type of imaging device. But at that particular stage, offering a questionnaire, like, is there one that you would suggest? Is there a preference?
Any validated questionnaire.
Is a DEQ5 too basic, or is that a good place to start?
As long as, to be honest, you're using the same one from time to time so that you can compare, right? So you're not just taking any single one. You just want to be consistent.
Yeah.
You pick the one that works with your clinic and the one that you like interpreting, and you just run with it. Okay. You got to start somewhere and then just go.
And as far as expressing, just with your finger, just press on the lid a little bit, that's good enough? Or do you need a tool to put a bit more pressure?
Well, there is the tool, right, the MGE, that applies the proper constant pressure. But yes, at the beginning, I mean, don't get mad at me, everyone. But yeah, sure, just start with, I put gloves, but start with, your thumb.
Right.
And see what you see, and then you're going to develop that habit of just looking all the time, looking at the lid margin for, any telangiectasia. These are things, we're already there, right? Our eyes are already in the slit lamp, so it just takes look down, look at the eyelashes,
Yeah.
So simple things that we can incorporate in our day-to-day.
So you mentioned that when you were graduating, when you were finishing optometry school, there was a shift of like, don't sample because there's better compliance with retailing. And so what words of advice do you give to somebody who is maybe sampling, not retailing right now? What's a good place to start? What are the benefits of doing that?
So the thing with sampling is that the patient won't necessarily take what you're recommending that seriously. They just think you're kind of reaching back, grabbing whatever and giving it, as opposed to the fact that...
Which is usually the case.
Right, it's like whatever rep came is what you're going back and getting, right? But the truth is, nowadays, there are drops that we're picking for a purpose, right? We are picking lipid-based drops. If we have MGD, we're picking different drops for different reasons. And that's the conversation I have with the patient, right? I have selected this drop specifically for your eye condition. And this is why it's important that we use this one, so that when I follow you up in 3 months, I can make sure that you're getting the effects that you need to get, right? So that's really where I would start. So to stop sampling would be a good place to start.
Yeah. And as far as now, when somebody looks to go and start to retail products in their office, of course, there's various options.
Right.
I have a feeling I might know which products you might suggest that doctors start to carry in their offices, but I'll let you make a suggestion and then maybe give us a reason why.
Okay, so first of all, there's a ton of research out there, and every company has their own research backing. So I always recommend that each optometrist looks at that. Use your reps, right? So meet with them, get the information. I love meeting with reps. They are the specialists in this field, so they know their product like the back of their hand, and you could ask all the questions from the research that you previously asked them to email you at that meeting, right? And then personal experience. So using the product on the patient and getting that feedback. Oh, wow, when I used this drop for this case, it really made a difference. That patient was actually really helped, and it made it so that I didn't have to go to step 2, 3, 4, 5 of my treatment plan. It kind of halted it. So I really do think that those 3 things are important.
Okay, good. And so what I was trying to lead you towards was that maybe Thea products would be a good place to start.
Okay, so let's do it. Okay, so, well, to be honest, and this is for sure, you could kind of look back. When I first started, 5 years ago in the dry eye practice, I really truly did start with Thea products. And that's an actual fact, because they had everything that I needed at the moment. So there was the mask, the Omega, the lid wipe, and the drop, and everything kind of came in a whole package. So I really did. So I have a lot of experience with Thea Duo, and then later on Thea Duo Gel. So yeah, I'm talking about it. Obviously, we're sponsored by them, right? So we got to be fully transparent.
Yeah.
But it is the truth that is the company that I started with at the beginning, and I do have great results.
Right.
So yeah, we can go through sort of which products I use when. My pleasure, but it's not because we're sponsored that I'm saying that.
But it actually, right, that's not the only reason why. But so let's talk a little bit about the benefit of the specific products, right? So preservative-free and the actual ingredients that are in there and why those are beneficial.
So I love preservative-free. I mean, obviously there's a case for everything, but in my opinion, if the surface is already inflamed and irritated, I want to minimize the amounts of irritants I'm adding onto the ocular surface. So for Thea Duo, when I use it, so I love the gel, to be quite honest. I love it.
So okay. Let's finish talking about Thea Duo for a second.
Okay,
fine. For again, if we're talking, so we do retail quite a bit of the Thea products in our office as well. But I love Thea Duo just because of how much, like to your point earlier, the positive response that I got back. It was this positive feedback. Patients kept telling me, "Wow, this drop helps me feel better," and I kept hearing that. So we keep recommending that drop because we know it works. But the gel, truthfully, I haven't been recommending all that much.
Okay.
And I fear because it's like too thick or something, but like I've heard from multiple other colleagues now that it's like, it's gold.
Yeah, it really is.
So
my speech for Thea Duo to my patients so that they understand why I'm going with this drop is that I say it has a component inside that helps not only hydrate your eye, but rebuild the front part of your eye. So that's how I explain it to the patients so that they know sort of what's going on. I don't tell them like the Trehalose, you know, blah, 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 but I'll phrase it like that. The Thea Duo gel actually doesn't blur at all. I use it on me. Yeah.
Okay.
Like I have some in my purse. So I literally will put it in, it doesn't blur at all, but it'll SPK and Thea Duo gel, like it gets rid of it.
Really?
Yeah.
Oh man.
I love it.
I need to start using that more. Okay, good to know.
Yeah.
Can I get some sample? I'm just
yeah, exactly.
I'm just joking. Not really joking. But okay.
We love samples.
We will get
like I literally like don't want a sample, but I want my purse to be full of them for me.
Right, for me. Or like at least so I can drop it for patients in the exam room.
Fine.
But I wouldn't be giving them out. So, oh my gosh, I lost my train of thought. Try to make a joke. It's that much work for me now. I can't even make a good joke.
It's like dad and mom jokes.
It's bad. Yeah, dad jokes come easy. Actual jokes, I can't.
Okay.
Okay, so what I was going to ask you, going back to Thea Duo and the gel.
Yeah.
How about refractive surgery patients? So personally, I'm finding I am usually telling them to stop whatever other drop the surgeons usually told them to get and please start using this because I'm starting to see patients with just overall better recovery. Would you agree? And have you seen the same thing yourself?
Yeah, absolutely. Any kind of corneal disruption, it works wonderful for. So because I work in the ODMD practice, they're kind of used to Thea Duo and they're comfortable recommending it also. And they recommend other drops, but it's just a matter of seeing how the eye's reacting. But definitely, I've seen great reaction.
Yeah.
Yeah.
We're actually even finding some of the surgeons in our area are actually starting to give Thea Duo to patients or asking them to buy that right after their surgery.
Right.
It's a good starting point. Not everybody's doing it yet, but a couple of them are. And so when I'm getting patients coming in, I'm saying, here's the drop I'd like you to use. And they're saying, oh, that surgeon actually asked me to.
How nice.
Great, excellent. Okay, so let's keep moving along that journey now. All right, so we've suggested that Harbir, 5 years ago, you should start retailing some drops.
Yeah.
Here's a great place to start. Profitability-wise, obviously there's benefits to that as well. Certainly something I saw myself. Once we start retailing drops, that bottom line starts to increase. So you're selling product in your office, right?
Definitely.
Let's move on a little further. What about treatments now? So what is a good entry point? So I've started to diagnose a little bit more. I'm staining. I'm seeing, okay, there's, evaporative dry eye. The tears are drying up too quickly. There may be even some staining on the eye.
Right.
I want to do something about it. So what's the next step?
I would still stick with at-home treatments as a baseline, as the place to start. So with a heating eye mask, omega-3s, lid hygiene, and the drop. So I wouldn't even only retail the drop in clinic. I'd retail this whole package. and obviously geared depending on what the patient has, right? Not everyone leaves with all 4 things, but or depending if they have Demodex or not, or whatever the case may be. But I think that starting with the basis like this, it's a great start. And there's a lot of patients that feel so much better. I had a patient actually last Friday who was like, "Thank you so much." I'm like, I didn't really do that much. You know, I was in my private practice actually recommending this as the basis because I don't have any advanced treatments there.
Right.
So I kind of see both sides, right?
Right.
So there I was like, look, we're going to start with this like therapy and then we'll move on. And I was like, it's just good quality products and you did the consistent work, right? It demands that they do the consistent work. I would also recommend, talking about consistent work, to give the patients written instructions.
Right.
Super key. It helps them do it at home and really stay compliant.
So one of the things that along my journey now coming to where I am, fast forward to today, that I really felt was a turning point, especially with the retailing the products, but in general with compliance with treatments for patients, was I created a little tear-off pad.
There you go.
And so I just designed it in Canva, I think it was, right? And so, you know, it's got like on the top dry eye treatments and it's got like 6 or 8 lines that I've printed with little check boxes and a bit of space underneath to maybe handwrite. So, you know, might say warm compress and I might write the name of the mask that I want them to use, eye drops and the names of the drops, and I'll check or I'll circle and I'll rip it and hand it to the patient. I always found that works quite well or has worked and has helped with the compliance. So you're right, writing it down. Because usually I'm sitting there and talking to patients, okay, I need you to do warm compress for 10 minutes. I need you to do this lid cleansing routine every day. I need you to use these drops 4 times a day. And they're like, you know, just like blank stare. Could you write this down for me, please? Oh, actually, you know, here you go. Rip.
It's like an hour of work that you did like on a Saturday, who knows when, just benefits and saves you so much time down the line in clinic. It's just that little effort in creating whatever tear-off pad with your logo. Then afterwards, you're just like so much smoother in clinic. And I don't blame them. Who would remember what we're saying? We're saying a million things, and half of the things, like I would have felt that it was so random if my optometrist was talking to me about omega-3s. I'd be like, where are you coming from? Left field, you know?
Yeah. I tend to over inform, which is a problem sometimes. Like obviously you want to educate your patient, but I feel like sometimes I'm doing a little too much. So I try to cut myself back and I write it down. Here's your instructions, right? Take this home. By the way, I like to share it. So if somebody's listening or watching and they're like, I'd like to create a tear-off pad like this, just message me and I can send you my little
Canva template. How nice is that? Well, I'd take them up on it. That's a lot of work. Yeah, that's good.
It's just $5,000.
That's it. Per pad,
Per pad, per piece of paper. No, seriously, if you're interested, I have shared it. Other people have reached out to me from previous podcasts. So if you're interested, I'm happy to share that. So let's go back to what were we just talking about? Retailing and treatments. Harbier, 5 years ago, has a question for you. Is Demodex real?
Yeah. Remember that question? Now it's like a huge thing. So Demodex and cleaning lids in clinic, I would say, is your biggest bang for your buck, easiest way to kind of like look like your patient's hero with minimal effort, right? Because genuinely after an in-office treatment to remove all that junk on their eyelids, they're saying, they're like, oh, I feel so much lighter, I feel so much better. And it's a great gateway into treatments because it is fairly easy to learn and takes not a lot of time and high benefit for the patient. It's kind of, we're all fed up of using the dental analogy, but it works a lot. It works well on the patient. So I'll just explain, like, you're here and I'm doing the cleaning so that when you do your lid wipes at home, it's maintaining. It's not doing the work, right? Because if you send them home with, you know, grade 3 Demodex, it's going to take a while to get to grade 1 if they're doing it by themselves, a little wipe morning and night.
So you're saying that Demodex is real. And it's a problem for people.
When it's an infestation, it's a problem. It's normal.
On the
face, you know. It's okay. I don't scare my patients also, right? Because they can get freaked out to hear like, you have a mite growing in your lashes, but a little bit's fine. And when it becomes too much and starts to impact the eye, then we want to kill it.
If you could like super like ballpark it, but like what percentage of your patients do you feel like Demodex is part of the issue?
Oof, a lot.
Yeah, like 50?
Oh, depends on the age, right? So Demodex, if we kind of look at the stats, after 60, it's 60%, 70, 70%, 80, 80% of people have it, right? So that's kind of the latest stat that I read. So if you
I only have like 25%, is that what you're saying?
Yeah, very good.
I'm telling you, these jokes get worse as the podcast goes on.
It's as late as the time goes.
So you'd suggest, as far as starting to do some sort of in-office treatment, lid cleaning procedure.
That's a good one, yeah.
It would be a good place to start.
Yeah, obviously evacuating meibomian glands is like wonderful.
So tell me about that.
So like your basic version that anyone can do is you need 2 rooms though, but so you don't monopolize your exam lane, but you can have your patient sit in the next lane over with the heating eye mask that they will take home eventually.
Right.
You warm it up, you have them sit there, and then you go in and you express. So you could literally start by that and give them, once again, like it's a head start.
Got it. No, I like that what you said about like, so because the at-home treatments are better, they work better as maintenance treatments, or maintenance procedures versus like the actual treatment. So if you can do something in the office to kind of start that, give that momentum in the right direction, then those at-home treatments are more effective. Yeah. Versus if that's what you're using to just go from like where you are to try to treat the whole problem, it doesn't work as well. That's what I found.
I think what I would say is it works, but it would just take longer.
Right.
That's all.
Okay.
It would just take longer to get there, as opposed to if you kind of gave them that boost in office. If you removed the obstruction and you cleaned the lashes, then the treatment will pick up faster, is what I've observed, versus just sending them home with all of it. It'll work, but it might take like 90 days instead of less.
Okay.
Yeah.
So what's the next level up here? So we're doing
Keep climbing.
We keep climbing. We went from total beginner sampling drops, not doing any treatment, to now we got questionnaires and we're diagnosing just with dyes and stuff like that under the slit lamp. And now we're maybe doing some microblepharoexfoliation and maybe we're doing gland expression. Yeah. What will be the next step?
Well, you got 2 fields of next steps, right? You have your diagnostics.
Right.
How deep do you want to go into your diagnostics? Into osmolarity, into visualizing the meibomian glands, into all those pre-tests, I would say, that'll really complement and help gear your treatment. And then there's in-office treatments, right? That'll be fun. So I think what ends up happening is you start off like this and you help a certain percentage of people. And then you kind of get to a point where you're like, I need something else. Because those, let's say you helped 50%, you're like, I need something to help the remainder. And that's when you kind of feel like, oh, okay, maybe it's time that I start looking into solutions. And I don't know about you, but you go to any trade show, there are so many new dry eye technologies and treatments that's why it's so much fun. Yeah. Yeah.
So let's say, let me ask you a couple of quick things on the diagnostic side. So if you were to prioritize a couple of pieces of diagnostic equipment, let's say now, okay, I feel like I'm seeing a good number of dry eye patients daily, and I'm recommending these things, and I got my little tear-off pad going like every other patient now. Right. Which piece of diagnostic equipment do you feel, and we're not,
I'm thinking.
What would you say maybe is priority, or ranking maybe 1 or 2 of them?
Osmolarity.
Osmolarity.
Yeah, osmolarity is crucial in my diagnosis and my management. Okay. And visualizing the meibomian glands. I find
meibography.
Okay. Of some kind. There's so many different ways and tools and everything like that, but those 2 I would say are key.
So tell me about, so meibography is pretty, I think, self-explanatory. You're taking a scan of the meibomian glands, you can see the structure, you can see if there's dropout. Tell me about osmolarity. Where does that factor in, and how does that change your treatment plan?
So the key is I do it on everyone for a first consult. Okay. Every time they come, they get an osmolarity measurement, and either over 308 or a difference between 8 between the 2 eyes, I will really be able to gear what I'm going to go through next, right? And the way I explain it to patients, which I don't know if anyone else uses this kind of language, but it might help if you do have osmolarity in your clinic, is I say I'm measuring the saltiness of your tears. So how salty are your tears? And that really makes people understand, if your tears are very salty, then they're going to burn and it's not going to be comfortable. Right. And we want to get it to a point where it's neutral, right? We really want to lower that. So it'll help on what treatment, what drop I'm using, right? To use a hypoosmolar drop or not. And really gear where I'm going, asymmetry between different eyes, how fast I'm referring for cataract surgery. There's a lot of different things that come into play. So I just think that that's a really important one. And then meibography, because it allows me to visualize the the potential and how fast we're going to get to where we need to go. And B, I mean, patients can literally diagnose themselves. When you take out the normal scan and then you show them their scan, they're like, oh, wow, we need to do something about this. And so not only for compliance, but to see afterwards sort of the improvement or lack thereof or whatever we're going. Yeah.
You mentioned cataract surgery, how fast you would refer to cataract surgery. Is that just simply because if they're hyperosmolar, is that the right term?
Yeah.
I always do this. If the osmolarity is too high, you are not going to refer them at that time. Is it that simple, or is there something else?
Well, I want to make sure that we get them to a point where it'll maximize the results, right? Because especially all the patients that we're seeing more and more are doing these premium IOLs. So we really need to make sure that the ocular surface is pristine before sending them. And it's just good all around because the patient will be much happier after, and the surgeon is much happier, operating on a clear surface and cornea and having the patient be happy. So overall, all around, I think it's just a really wonderful.
Definitely a focus. Definitely for any refractive patients that I have, I always tell them it's so important to optimize that ocular surface. You know, I haven't personally thought much about osmolarity, so it sounds like that might be something I need to invest in. So let's move on to now on the treatment side of things. If we were going to level up on technology as far as treatment, really the big kind of things I feel like that are getting a lot of attention these days are RF and IPL, radio frequency and intense pulse light. There are some other sort of thermal pulsation treatment options that have been out there for a while now and still seem to be very beneficial. Do you think that there's a better entry point into like that more advanced treatment technology for somebody, or like do you think like RF versus IPL or both together? Do you have that we're kind of getting a little bit, I feel like we're jumping a little bit here quite a bit, but there's not really too much in between. I don't know if there is. Maybe I'm missing something.
Yeah, I think at this point it would really depend also on the clinic's ability to, you know, go to the next step, right? Because there are options at each sort of price level and they are effective, right? I do still use thermal pulsation and it's effective. But I use IPL and RF for different reasons. But it's normal that if it's not a referral center, you're not going to spring for all of them, right? So it is a significant investment. Let's just go with IPL and RF for now, because that's sort of, I guess, the one that, like you said, is gaining in popularity. But I can easily say that it is the treatment that revolutionized the clinic. It really took patients, let's say that we were helping 70% and now we're close to like 95.
Wow.
So it really took it to the next level. And the combo, which I know there's a lot of, some people just do IPL, some people just do RF, some people do it the same day. So it's kind of still being figured out. But having those two options really is key. And
do you combine them same time?
I do.
Yep.
Yeah.
Are you comfortable sharing?
Yeah, absolutely.
One
first
or the other? Which one do you do first?
So let's say the first time, it depends, right? If the patient has, you know, obvious rosacea, I will start off with IPL.
Okay.
Let's say first exam, I won't do both.
I see.
Okay, so the first one I'm going to do IPL, and obviously if that went well and I layer RF on it the next time and something goes iffy, then I attribute it to the combo.
Right.
So I won't do it the first time, but I do find again, some people do IPL before, RF before, right? There's a bunch of discussions, which is fun to me because it means that there's, you know, interest in the field and that eventually we'll all come to a consensus, but everyone's trying, which is the point of being at, you know, the forefront of something.
Right.
So I personally do RF before. I do it before and then I warm up the lids and then get it all nice and red, and then I do IPL on top of that. And that's simply because that's how I was taught by different Canadian people who came before me, you being one of them, actually. Remember? I called you and I was like, hey.
Don't get me in trouble here.
No, it's
Somebody's
not.
going to call me and say, that's the wrong way.
It's not the wrong way. There's no wrong way. No,
but no,
right.
You're right. That is the way that I do it as well.
Yeah.
And then what about expression?
I do it all the time.
Yeah, but as far as RF IPL, do you do RF IPL Express after, RF Express IPL?
RF Express, IPL Express.
Oh, wow.
I know.
Double
it's
Express.
The Courey Double Express method, which I don't know. I just
that's
did
it.
myself.
That's got a new title now.
Yeah, I guess.
The Courey Double Express method. We're gonna TM that.
Because legitimately, like nobody. it just to me kind of made sense, and I actually see great results with it, but it takes long because you got to sit the patient up after RF, express, and I do upper and lowers, and then put them back, get them set up, IPL, and then when they sit back up, I feel like I get the remainder.
Interesting.
Yeah.
So we have now we have a trained technician esthetician
good.
who does. Do you do the treatments yourself?
I do, which is another thing that I realize I'm like a lone soldier. But yes, I do them myself.
I started that way, but it takes a long time. But so so the protocol for us is RF, and the way our chair is like reclined, we have one of those.
Oh yeah, like
those like ring light mirrors that people use for like doing lashes and stuff.
Oh, cool!
Right?
So you can express
not mirrors,
like right there.
Not mirror, but magnifying glass. Yeah, so like the patient's laying back, and we bought it on Amazon. It was like $30. So we just roll that thing over, put it over their eyes, and through there you can see magnified. And so we'll express, and then put the shields in and IPL. But so to express again is not that much more work because the patient's always in the same position. So I might add that in.
Express gently. I also think this is very important, right? So we don't want to crush the glands, right? So I'll do like it's very gentle, and whatever comes out in the first round, and then after IPL I get the remainder. But it's usually not like a very tight.
Got it.
You know?
I think that's a mistake that I certainly had made before, and I think others maybe are using a bit too much force, especially when you get in there with the whatever that's called, the meibomian gland expressor, whichever one you have, the forceps. It's easy to. There's different names for them, right? They're like named after people, but they all look the same. Anyways, but when you get in there, you have that. It's easy to put a lot of force on there, you know, inadvertently.
Right.
So now, so RF, IPL, and expression. I'm going to adopt your new double expression technique. Do I have to pay royalties for that, or no? Okay.
Let me know, actually. It'd be fun. Let me know if you see as much success as I did when I started doing this. I feel like, I don't know, the next appointment, people were like, oh yeah, that last time really worked. And I was like, oh, okay.
Okay.
So actually the first time I'm like actually vocalizing that I do this, because I was kind of just doing it in my corner.
Heard it here first.
Hopefully
Heard it
that's
here first
fine to do.
On the 2020 podcast.
No, but really, just chatting with you.
No, I appreciate it. No, I'm just joking. But it's no, that's great. I appreciate you sharing. Those are the types of things that I think people who are listening are going to gain from this, is like those little pearls, right? This is what Claudine does in clinic, because you're seeing these patients day in, day out, every day at your clinic, whereas most of us, like myself, sure, I got lots of dry eye patients, but like I'm not doing as many of these treatments as you are. I'm not doing as many of these other procedures as you are. So learning from someone like you is going to help as we implement those things in our own practices. So thank you for sharing that. So we talked about RF, IPL. Is there anything more you want to share about those technologies? I know there's just so much out there right now on that.
It's so great. Honestly, it's been a great addition. I'm so happy. And it does look like a big investment, and it is. Actually, it doesn't even look like it. It is a big investment, right? Yeah. And it's just a matter of sort of calculating how you can monetize it. But genuinely, it has been quite easy to do when you see the results. And I feel like a lot of patients come back to me and say, I wish I knew this was going to work right away. Like, I wish I knew this was going to be like this. I would have done it sooner, or I wish other people would know who are on the fence. Because once they feel better, yes, they have to spend a little bit more for the initial treatment, but they're saving a ton afterwards on not having to do a repeat, intense treatment.
Right.
So, yeah.
Speaking of repeat treatments, in general, do you have patients coming back on a kind of a routine every 6 months, every year? Is there something like that you see regularly?
Yes, so I do 4 treatments initially, spaced out between 2 to 4 weeks, and then I'll do a follow-up in 6 months, and then another one 6 months after that.
And are you doing treatments at those times, the 6-month mark, or is that just assessing?
Usually I am.
Okay.
Usually I do, and I boost it, but I see the person first, and if they're coasting, then we'll coast with their at-home treatment. So I always tell them, I'm not going to do this for fun. I want this to be beneficial for you, and this is going to be something that will benefit you. So usually we kind of have a 5-10 minute discussion first. I check all their scans, because they re-go through that whole loop of everything, and then following that, I'm able to really decide, okay, yeah, let's do one extra one today, or maybe we'll do it in 6 months.
Okay, good. So I'm finding similar. It is based on the patient and their outcomes and their symptoms.
Yeah.
There's some patients that we have coming in every 3 months because they just swear that this is the only thing that's helped them.
Yeah.
And so they just keep coming back every 3 months. And if that helps them feel good, then great. And some who come back 6 months or a year, or not even for a couple of years, just depending on how good they feel.
Right.
One question that's a tough one, I feel personally, to answer is, like, how do you define success for a kind of a moderate to advanced dry eye patient? Is it based on their symptoms? Is it based on the signs that you're seeing? Is it a combination of both? Like, just to kind of put more context to it, one of those patients who comes back every 3 months, he's a relatively young guy. He's in his early 40s. And before he came to see us, he was using drops at minimum every hour while he was awake, but he said on average probably 20 to 25 times a day.
Wow.
And that was the only way he was able to function. Otherwise his vision would go blurry, he wouldn't be able to read, all this kind of stuff. He's had some corneal stuff, but he's tried a bunch of other treatments. So we did RFIPL, did the series of treatments, and now he needs drops 5 times a day.
Right.
5-6 times a day. Where if you were to compare that to another person and tell them, okay, you're going to need to use 5 drops 5-6 times a day, they would like lose their mind. Like, what? That's so much.
Yeah.
So the answer to what's successful is obviously going to be dependent on the patient. But do you look for certain things? Do you lean more on symptoms? Do you lean more on signs? How would you?
No, that's a great
define
question.
that?
So I'll tell you exactly what I do, and this might be another thing that you'll let me know if this is what you do in clinic. So the first time I see someone, I will literally in my chart it says goal, okay?
Oh, good.
And I ask them, I'm like, what can you not do today because of your dry eye that you would like to start doing in the future once we get better? Because I was finding the same thing. I'm like, oh my God, how do I measure that they're happy essentially, and that this is, so I measure it based on how they're feeling. Obviously, I will continue treating if I see pathology, but for me, for the patient to be satisfied, for example, your 5 drop a day patient, that's success. Right. Because he must be so happy that he went from 20 to 5. Yep. And then maybe kind of interlace in some other different treatments in there, and then he's golden. He's 3 times a day. Right. So I say, what's the goal? So let me give you a more recent one. What did she say? Oh yeah, she literally said, I love reading. And now I could only read 5 pages. I have to put it down, I have to blink, I have to look away, and it frustrates me. And I'm not happy and I'm not in a good mood because I cannot read more than 5 pages. So in my chart, I write, reads 5 pages currently, would like to read more, done. And then I look at the patient, I'm like, okay, so this is gonna be, you know, a starting point. And every time I see you, you'll let me know, are you able to read 1 more page, and blah, blah, blah. So I really, really like niche it down to that person and specifically target them and their goals, and then they're happy, right, at the end. So we kind of get the my side happy, right, which is all the objective things that I'm looking at. But ultimately, if everything I'm looking at looks fantastic and the patient is not happy, I don't consider that a success.
So even though you need the pathology to improve, the signs to improve, you do weigh the symptoms pretty heavily in that success.
Yeah.
But I think that's awesome how you do that. Actually, that's such a great suggestion of actually writing a goal in the beginning. I find myself, because you know, with dry eye treatment, a lot of the times it's quite gradual.
Yes.
And like after 6 months of doing things, like patients are going to be like, oh, I'm not sure if I noticed that much difference. But I'll go back to the chart, our first chart, and I'll say, well, you complained about this. Do you still feel that? Well, actually, no, not really. Okay, you also complained about that. How's that? Oh, that's gotten a little better. You know, like, so, and when you do it like that, then they're like, oh, actually, yeah, it has improved. Right. But because it happens so gradually, they don't have that kind of like comparison. So actually writing down a goal in the beginning is a great idea, because then you can say, well, look, you said you wanted to read this many pages and you can.
Yeah, so, or you've exceeded it. And so it goes goal, and then let's say we have OSDI, right? And that we could show, you know, these were your numbers at the beginning, and these are your numbers now. Right. So different ways of benchmarking it, but I added the goal in because I feel like everyone comes in with a frustration, with a pain point. And so I'm like, what is your pain point, and how could we help improve your quality of life with this treatment? Because that's what matters. These are people. They're sitting in front of you, and they want to do something that they cannot do. Right.
That's excellent. Really great advice. Okay, so let's go on. We talked about some of these advanced treatment options.
Right.
Want to list a few that I think are maybe more advanced, but they're things that I'm not really doing, and I think others maybe we've all heard of all of them, but maybe we're not really doing them that much.
Right.
So sclerals we're going to talk about, but amniotic membranes, punctal plugs, autologous serums. Am I missing something? Some of these more kind of maybe things that maybe require a bit more expertise. Where do you fall on some of those?
So it's different because this province by province is also regulated differently. Let's say when you're talking about autologous serum and all these kinds of things. And I do think they have a place, absolutely. I don't do plugs that much, to be quite honest, simply because there's usually a ton of inflammation on the ocular surface. So I feel like if I'm plugging it, I'm just keeping that inflammation on the surface. But then again, everything has its little place. Sclerals is the one that's in this, like category that we're talking about that I wish would kind of be pulled into an earlier phase, because fitting a scleral on a dry eye, meaning otherwise a normal cornea, right? No pathology, no cone, no pellucid, no nothing, is a great way to start fitting sclerals because you're fitting it on essentially a spherical cornea. So it's a nice, simple way to get into it.
So I've heard that we can use, I've seen some things that colleagues have done where the cornea is really beat up, like a lot of SBK, it's really rough shape. And they put scleral on top, and of course it creates this barrier, it bathes the cornea in some solution, and within a couple of days, at whatever period of time, but it seemed relatively quick, the cornea is looking a lot healthier. Seems amazing. Okay, so a couple of questions for you. A, does it work?
Yeah.
Okay. And B, isn't it hard? Like, isn't that a big process to go through? Like, as you know, like I've called you as I just started to fit sclerals very recently.
Yes.
And I know you're a huge advocate and a big fan of sclerals, and you've really helped me kind of get more encouraged to do it. But to me, so far, being so early in the journey, it seems like such a process to fit a scleral lens, right? Because I don't, it's not so quick and easy for me. Doesn't that seem like too much of an effort to treat dry eye? Are there alternatives that would do it better?
Well, if we also think about it in the other way, in the sense that you're also providing them a solution if they wear glasses to wear something else, right? It's not just a treatment in the sense that now they can go glasses free and they're getting their dry eyes treated all in one, and their vision is clearer because they have a more regular surface. It really is, how could I say it? It does look daunting, and I completely agree. But can I try and kind of like simplify it to the bare bones of it? Because truly, you could take your trial set and pick any, right? You could pick any, let's say 7/9, okay? You take it, you just fill it with fluo and liquid and put it onto the eye. And based on what you see, do you have an OCT?
No.
Okay, so you could just evaluate, right, with the thickness of the beam and the thickness of the actual fluo you're seeing, if you do like a little slit. And based on that, you're able to gauge if you want to remove one or put one on. So I think a lot of the maybe apprehension, and you'll tell me what it is how do I pick the first lens? Like, this looks like such a process. But you could take any lens and then insert it, evaluate it at the slit lamp, and if you're kind of close, you could literally refract over that and do all your calculations after the person leaves, right? You could compensate and you could do all kinds of stuff afterwards. So the reason I think is great is because you're giving them kind of a contact lens option, which probably they couldn't wear because of the state of their cornea.
Right.
You're healing their cornea as you do it. And also you're really just doing it in a way that hopefully doesn't, at first, it definitely will mess with the flow of your clinic because it's new.
Right.
Anything you do that's new is like, oh my God, what a process. But the more you and your staff, this is kind of like this is a teamwork effort thing. I don't think you should do the whole thing yourself.
Right.
But the more you guys get into the groove, I think you'll see the benefits of it.
Okay, well, I'm excited to try it. I think that's a big part of it is I need to set up a bit more of a system and a protocol around who's going to do which step, just to streamline it a bit.
That's it.
So when you put that lens on, I know there's normally some solution that you put into the lens. Is there a benefit to, or can you use something like a Thelos Duo in that lens, to have that solution now covering the surface of the eye?
Yeah, absolutely, and it'll go and start healing and working on the cornea even better. So absolutely, I use Thelos Duo to fill it. I can use other drops as well to fill it. This is like a personal preference. Like, you ask any fitter and they kind of like their little drop, but you could absolutely use Thelos Duo.
Okay.
Yeah.
Is that fine, like in general, like for scleral lens wearers in general, or is that's something you'd really mainly do if you just had somebody with really dry eyes?
But then you got to keep in mind that all these things, also patients, there's like a cost factor, right? So they're filling up their lens. Are they are they okay with it, or they're dropping half of it on the floor when they're trying to insert, and then they're
Right.
using half the bottle,
Right,
you know?
right,
So then you want to go for something more viscous. If they have bubbles in the lens, in insertion, I'll go for like a gel drop so that it's easier to manipulate. So this is, again, it's kind of like picking your drop for your patient, right? So this one is really like case dependent. But if you're saying like, can you? Yes, you can.
Sure, you can, but in theory you can, but you wouldn't in practice.
I would for some patients.
For just for the dry eye patients, not for the average scleral lens contact lens.
You could do it too.
But cost-wise, it would be.
It depends. Like that's another thing, right? So I give all options, and then it's up to the patient to determine what they could buy and what they can't buy, right? So I don't give them I don't assume, for example, like, oh, I'm going to give them the less expensive one. No, I'll say this is the one I recommend, and then if not, then my tech will kind of play around with, oh, this is another good one. Maybe it's a little less, but at that point, yeah.
So speaking of cost, sclerals are not inexpensive.
Yeah.
So does that get in the way of making this suggestion, or for patients taking your
No, but I see how it could, in the sense that I'm very comfortable with it, so I recommend it with confidence. So, and then as well, it's one pair. Yes, you're spending a lot of money, but they last like 1-2 years if you're taking good care of them and stuff like that. And then imagine what they're spending on the rest of the stuff, right? On all their at-home treatments, on IPLs, on RFs. So it kind of goes in the mix. If this is a good treatment for them and they can do it, then they usually just go for it.
That's a good point. So if this lens is able to really solve a lot of their issues, it will maybe take the place of having some of those other treatments and end up costing less potentially. I guess you still have to get to the underlying cause though, right? So this is like fixing the cornea, but then we still got to treat the MGD if that's there.
Yeah, of course, of course.
So maybe more of an additional cost, but it's still something that will help heal that cornea like some other treatments probably cannot.
Yeah, it's another thing in our toolbox, right? So I consider it like I have all these options in my toolbox, and which one am I going to pluck out for what patient? And I think that's what's fun. It's kind of like at the beginning, you're like a detective, you're figuring out what's going on, and then you're using what you have. And even if I don't do something very often, I'm like, okay, this would be a good case for that. Like, let's try it, let's go. And I'll tell the patient, you know, you're a good candidate for this, but for X, Y reason, so that they always know what's going on.
Right.
My patients genuinely always know what's happening at all times.
That's good. Well, it's important, especially when you're going to be making some pretty significant recommendations and some somewhat invasive recommendations as well as far as treatments go. The other question about sclerals, which I've heard come up, is the concern about trapping sort of inflammatory cells and things under the lens. Is that an issue? Is that something you see as being a real problem?
I haven't seen it as being a real problem because, I mean, these patients, we treat them a little bit before, but it really just tends to heal with the scleral lens on it. So I haven't noticed anything. And if we did, we'd kind of tweak as we went. Yeah.
And on the note of inflammation, in general, where do steroids come in for you? How easily do you prescribe? How often do you prescribe steroids?
So I will prescribe them if needed, but I'm not. It's not like my first go-to, and I do this a lot, and I see a lot of people, and I say this because I know that at the beginning, you know, everyone's like, go with steroids, and that is totally fine, and there's nothing wrong with that, but I genuinely find that with solutions we have at our disposal, I've had to use them less and less, and now I don't use them as much as so for example, Thea Duo Gel, for real, whereas before I might have put a steroid on that, I'll start them on the Thea Duo Gel and I see a significant improvement, then I'm not going to start them on the steroid for fun, right? It really does help in those mild cases, to moderate even. So, but yeah, if they need it, yeah, they're getting it, you know, and I'm prescribing it, but I wouldn't say I'm like very forward with it.
I tend to be, I think my threshold for prescribing steroids is very low.
Yeah, but that's cool too.
But again, now that I know that Thea Duo Gel works so well on SBK, that's certainly going to become my first line in that case.
You could try, and then that's it. See how it works with your patients, and then you'll develop that comfort, right? But it just happened this way that I was starting to do that, and then I thought, oh, funny, that patient I would have normally put him on a steroid, but now I guess I don't have to.
Right.
And then it went that way, you know.
And how about like immunomodulating types of drops? Are you recommending those quite a lot? Is that something that's commonly used in your toolbox?
Yeah. When needed, absolutely. But we get there. right?
Yeah.
Once again, it's just not my, okay, so here's my philosophy, and I tell this to my patient.
Is it Hakuna Matata? No, okay.
What a wonderful
I'm
phrase.
just kidding.
So,
Good for you.
so what I say to my patients is my first job is to figure out why this is happening, okay? My second job is to try and get your own body to re-function the way it should,
Right.
okay? So that's my philosophy, right? So it might be a little bit, granola or organic in that way, in the sense that I truly want to give patients the ability for their eyelids to function as they did or as best they could.
Yeah.
And then I will sit there and layer on adjunct therapies. So that's why sure, maybe before it was like steroid and immunomodulator. That was kind of what we did right out the gate, and we're like, okay, go. And now I'm more of the mindset of, okay, I talk a lot about nutrition, right? Dr. Mila put out an amazing guide, and she works with another Dr. Futch, and I really refer them to that. I will refer them to use other different kinds of things that really will heal them from the inside out, which I believe that's what IPL and RF are doing as well.
Yeah.
So all of these things I use, but I try and get the patient to have their own body healing as much as you can, so that when I do put something and layer on top, it's not going against it, right? Like we talk about the cosmetics, right?
Right. No, that's a great, ultimately that's what I think we should aim for, is for the body to function the way, in its best, at its best, if we can. And shout out to Dr. Mila Yusufova, and go check out I Thrive Wellness. It's actually really great. I've been doing that. The doctor side of that protocol where you get the training. It's been nice to kind of get that, and it has inspired me to have more of those conversations with patients about how nutrition can affect your eye health, like your gut health can affect your eye health, right? If there's inflammation in your body, it's more likely to lead to inflammation in other places. So really, really good to try to control that everywhere. Okay, so I think we've gone through, have we missed anything? We've gone through a pretty long journey.
We did a lot, yeah.
Yeah, so we started with Harbir 5 years ago, who was sampling drops. We stopped him from doing that. We got him to start retailing some good product. We got him to start using questionnaires and checking for dry eye, and even doing, then recommending home therapies, warm compress, that stuff, and then maybe even doing some simple therapies in the office, like blepharoexfoliation, and then we stepped it up. Bought an IPL and an RF, started doing that, seeing good results with that, and then I may even start doing sclerals for dry eye, and I'm going to let you know how that goes.
Yeah.
What have we missed anything? I think we covered most of it.
We did a big
good.
Yeah, good
So
little summary.
What else you want to say to the people out there?
Oh my goodness.
About dry eyes? Like the thing again is, like, this year, just to kind of like be real for a second, like every year there's like something that's like the hot thing, right?
Yeah.
Or for a couple of years, there's something that's the hot thing. Now, dry eye was like the hot thing for a couple of years, and it's still popular. Like, for example, we're in Toronto this weekend. The Dry Eye Summit's happening. That conference is growing, and it's always sold out. So clearly, there's still a hunger for this information. This year, I've personally felt a lot of talk about myopia management. I've had a lot of that on my podcast as well. So I feel like sometimes the audience maybe gets a little numb to, like, okay, dry eye again, right? But I wanted to kind of create a conversation here that was really, really a full spectrum of things, not just like talking about one dry eye topic. So, like, on that note, do you think there's anything else you want to share? Like, there's still lots of our colleagues out there who are not really doing a lot of dry eye because they feel like it's tough to get into, or it's too much hand holding with the patient, or anything else you want to kind of share that might help encourage those colleagues to get into it a bit more?
Yeah, absolutely. There's two things. I think the first thing is doing something is already a huge step, right? Anything you do doesn't have to, you don't have to go out and get the IPL and RF on day one, right? But just those little modifications that we talked about at the beginning is awesome. Yeah. And then, like, if this isn't your thing, it's okay. It doesn't have to be your thing. There's things that aren't my thing. But let's get in the habit of inter-referring. Right. And that's what I love, right? So I work with a ton of optometrists in my region, and they'll refer to me. I'll do the treatment. I send a report. I refer back to them. And I just think this collaborative model is where it's going. So it doesn't mean it has to be your thing. If you don't want to, dive into it, it's okay. But it still has to be your thing to identify and address the person's problem.
Right.
That's all. So if someone's coming in and they are voicing that this is something, and you're just like, okay, I do not want to go down this path. Find a friend who does,
Yeah.
and who loves it, and then build that rapport. And whatever you're good at, because 100% you're good at something too,
Yep.
that friend will refer right back,
Right.
right? So I just think that's something that I wish we did more of,
Right.
and I would continue to advocate for that because it's just such a beautiful profession, optometry, obviously. I adore it. And I feel really privileged to be part of it. And we all have sometimes something that we love a little more. So why not maximize and make it the most efficient profession by
Right.
inter-referring to each other?
Love that. Great message. Great message. Thank you for sharing that. I think that collaborative approach is so important for our personal, kind of success and satisfaction in our own work, right? Like you get to do more of the things that you love, and you can refer out the things that you don't love, and
Exactly.
so refer them to someone like yourself who loves doing it.
That's it.
Everybody's happy. The patients are happy. The
Yeah.
patients see that we have a cohesive profession and we're supporting each other.
Mm-hmm.
Ultimately, and it's gonna protect our profession from potential intrusions or whatever. That's probably not the right word, but like other people, other entities coming in and potentially invading the profession. I was listening to something someone said yesterday about like what happens in that case. Let's say somebody doesn't refer or doesn't treat, or we have those types of gaps in the profession or in our treatment. Ultimately, if that gap remains too long, something is going to come and fill that gap, and that
Yes.
something might not always be something that we want there, right? So if we stay cohesive and we work together, we're filling all those gaps
Yes.
together.
Yes.
I think that's going to be best for the long-term, success of the profession as well. So thank you for sharing that.
Completely.
That's it?
That's it.
That's the end of the third episode?
That's it. Thank you. Thank
Sad.
you so much.
We recorded 3 episodes and we're all done.
Yes.
I think Hakuna Matata is the best.
That was the best part. Yeah,
That was the
that's
best.
the one that we're going to quote
right.
now.
Thank you, everybody. Thank you, Claudine.
Thank you.
Really,
Thank
I love
so
you. You're
much.
amazing. Thank you so much for
you.
sharing so much of your insight on these 3 episodes. There's been so much amazing, just gold. So anybody who listens to this, I know they get so much out of it. I want to say thank you again to Thea Pharma Canada. You guys are the best for supporting this episode and this whole series and just optometry in general. Thank you so much for all the support. And thank you to everybody out there for listening to the 2020 podcast, Canada's #1 optometry podcast. I'll see you guys in the next episode.